Dr. A.K. Das, welcome, sir.
Thank you.
Sir is presently the Professor of Medicine and the Head of Department of Endocrinology at Puducherry Institute of Medical Sciences. He is also the ex-Dean and ex-Medical Superintendent of Jawaharlal Institute of Postgraduate Medical Education at Puducherry. And sir has an experience of more than 33 years in teaching undergraduates and postgraduates. So we are keen to listen to you. Over to you, sir.
Thank you, Dr. Reshma. Thank you, Dr. Shah, and thank you to my very dear Manoj and Purvi, and the wonderful meeting you have organized. Ian has said it all. I will not repeat it again. I have a very important task to carry on. In next 19 minutes, I'm going to speak about the insulin initiation and what are the solutions to various challenges that we meet. Dear friends, what are the objectives of this presentation? Number one, we'll recognize, and most importantly, that's what Manoj told me, challenges are there, but we need solutions. What are the solutions to overcome the common challenges encountered during insulin pre-initiation? This is a term, pre-initiation, before we really start insulin, and the initiation, both I'll deal together. And if diabetes education or insulin education is the way, we'll try to understand how to identify the various methods of insulin education at the pre-initiation, initiation phase. And what are the evidences that this education highlights the improvement in the insulin acceptance in our patients. The threefold objective of my talk today. I must mention, like air, water, and light, insulin is a birthright, is not a privilege. Therefore, this discussion today becomes very timely, very important, very contemporary, very challenging. Number two, insulin initiation will explore the various options, how to initiate the patient. And number two, how can we make an intelligent choice for our country, our national initiation examples and ways to do it. Now, type 2 diabetes is a chronic disease that requires a treatment for the insulin deficiency, for the glucose control, for the insulin resistance, it also to prevent complications. Even though insulin is the most effective, my dear friends, and very widely used, less than half of the people for whom it is intended, it is used. 49%, 47% of the intended population use it abroad. In our country, Mohan and Manoj and Puri will agree with me, Reshma will agree with me, less than 30%, to be exact 29%, including along with oral 31% of person use insulin for whom insulin is essential. Now, so therefore, what are the challenges? So challenges are many. I'll discuss it under clinician factor, that where we are responsible for the initiation difficulties, the patient factor, the psychological factor, I call it psychological insulin resistance. In fact, literature describes it as that, not my own invention, and the various biopsychosocial and of course economic factors that hinders initiation, and also few health system related factors. Now, therefore, our concentration today is not on the challenges but the solutions. Dear friend, this was one of the meetings we had this year, last month in a workshop, how to bridge the gap between the innovation and the adoption. Today, we know that the insulin innovation has been great, fabulous, and outstanding. But the adoption is much less. As you see here, only 31% people with diabetes are being managed in my country with this particular instrument called insulin. And you know, whether it is monotherapy, we start with one drug, start with the second OAD, then we start with the third OAD. But today, our own work in the landmark study and various other works clearly shown that addition of the fourth OADs, you can find it degrows, the H1C really goes up. And if you look at the insulin initiation and in contradistinction to various other anti-diabetic drugs, you will find that the insulin initiation is often delayed beyond 10 years. So initiation delayed at least for 10 years. Dear friends, I'm very passionate to mention that insulin metformin came almost at the same time. And you know, today we know that insulin is number one, number two, number three drug, and India has the pride of using it much earlier than it came to United States and Europe. Now, therefore, even though the insulin today has become the number one drug, insulin is standing far behind for the initiation. Even though we have so many options, more than 12 options of treatment and 12 options of insulin treatment, various types of insulin treatment, only 1 in 5% have this drug that is recommended to them. So there's disparity between the insulin and the metformin. Dear friends, we have various options, but to make a long story short, the most important option of starting insulin is the basal insulin. So number 1, number 2, number 3 choice is basal insulin alone, or with the OAD, we call it BITS therapy, bedtime insulin, bedtime long-acting insulin, and daytime sulfonylureas. We have other ways of treating it also. Few people give with the premix, people give with multiple rapid injections. I will just carry a small story. Reshma madam, give me the time. It was between Serasi and Luft, 2 IDA presidents. They said they were discussing whom to love, which deity to love. He said, love anyone. None of the love is wasted. Then they added, give insulin anyway, it is never wasted. So I personally believe basal is the most important initiative instrument, but one can, if not, one can give in other ways also with caution. I'll discuss in a minute. Dear friends, why basal is the good option? It can be used in the early phase ideally, but can be used in other phases also. Effective, significantly lowers the significant low rates of hypoglycemia, lower daily insulin dose, lower monitoring cost, and offer the things that are very important for us. Now, dear friends, how do we sensitize patients about insulin therapy at the pre-initial phase? Dear friends, I brought for you 10 case scenarios. I'll go through very quickly. I have less time. Number 1, we have to tailor the need insulin sensitization strategy based upon the 10 clinical positions in the disease spectrum. You know, diabetes is a heterogeneous disease. There are heterogeneous spectrum of the disease. So with diagnosis, when there is more than 9%, we have to tell the patient, this guideline says we have to initiate at this stage. When target glycemic levels are not achieved beyond 2 or 3 oral anti-diabetic drugs. Patient has diabetes more than 10 years. And I know, I always believe to bring in the communication, the insulin very early and demonstrate to the patient that even though it is called type 2, even though it is called previously non-insulin dependent, at some stage of the disease, one requires insulin and nothing is like insulin. Number 2, if the patient not at target, we have to motivate, we have to reinforce patients on the long-term goals, because educate the patient that to achieve long-term goals, that's a complication-free life, which Mohan will speak about. Now, insulin is a must, and it's always needed. And also, we have to talk more actively. We'll call it the motivational interview. We have to provide information on insulin efficacy and safety and its role in preventing complications. I have no scientific evidence to tell before you, but have anecdotal evidences that insulin provides a longer life. Dear friends, the next case scenarios are 4. Number 2, again, more than 2 or 3 OADs on control. Number 2, patient developing complications because of lack of control. And glycemic control is not there. Therefore, we do not have a good quality of life. We have a lot of comorbidities and complications. Therefore, we have to educate the patient about the consequences of complications and the importance of insulin in deferring complications or even postponing the complications or even preventing it. So therefore, these are the solutions, some of the solutions to make the patient that we have to initiate insulin new. Please take it home, discuss with your family members and agree to this proposition, which is for benefit. We have to tell the patient, we have so many areas, so many gamuts of treatment, so many instruments, but insulin offers maximum glycemic efficacy. And insulin, it has been said rightly, quote unquote, insulin never fails. Any degree of hyperglycemia, insulin can bring it down, as you show in this particular cartoon. And we have to also say that you have some problems. We recognize it. We call it insulin distress. It has been widely discussed. And how does it impact diabetes management and how you can conquer it? Dear friends, we have to tell at the outset, I have got 6 mantras that I always speak to the patients at the initiation, long before the CCT and the UKPDS. It was told by the diabetologist that insulin gives a great sense of well-being. Forget about the control, great sense of well-being. It never fails. It can be combined with everything from sulfonylureas to SGLT2 inhibitors. Is an ultimate panacea for all treatment and can be used at every stage of the disease and help achieve for our patient a life which is dignified and full, FULL full, despite diabetes mellitus. Dear friends, when the patient has a lot of queries and emotions during the pre-initiation phase, when patient initiates the patients on the insulin therapy, they face a variety of complex emotions, which act as obstacle for timely initiation. I'll go through the stresses. Number one, why insulin? For me, pills may be better. So number one is apprehension. Number two, am I really sick? Can I not pull on further with orals? Denial. I'm not that sick. The fear of needles, the needle phobia, the distress, patient falls at our feet saying, don't start insulin. Have I failed to manage my insulin correctly? The hopefulness. Now, there are really some biomedical limitations like visual, tactile, or the elderly people motor dexterity. But dear friends, to make a long story short, we have technology today like click count, like various ways where we can take over these biomedical limitations. Psychological limitations is very important. I will come back to a minute. The fear of the social ostracization is insulin taking diabetes, and the lack of financial support is a great issue in India. But today we have insulin for everybody, and it is available at the various prices, so one can really afford it, and government also supports it. We have negative reinforcement society. This I allow me to dwell 5 seconds. You know, I have written that this in India happens in abundance. Everybody was nothing to do with diabetes, nothing to do with society. They say insulin is a bad instrument of treatment. So there's a negative reinforcement. We have to overcome it. And RSGI really did a program to do away with the myth and say insulin is the best. Dear friends, what are the impact of this insulin distress on the management? Number one, it reduces the compliance. There's a greater psychological distress, more diabetes-related hospitalization, increased risk of complications, prolonged periods of poor glycemic control, and poor intensification, with my colleague Rajesh is going to describe to us. So distress has to be addressed by psychological counseling. Dear friends, how do we overcome these distresses? Number one, I call it AEP approach: ascertain, explain, and problem solving. Ascertain, explain, problem solving. Ascertain, we have to sit with the patient for the solution. Ask patient upfront, what is your fear? What is your real objection? What is your real concern? And take cues from that. I'll come back to a minute. We have a mnemonic called listen. I'll come to it in a minute. Now, number two, we have to make a shared decision making after explaining to the patient that why insulin necessary. If we're able to communicate perfectly, most of the patients will affect. I remember how mankind desire has started from the beginning. All of us, without exception, want to live long and want to live a good life. So insulin, why necessary? We have to explain to them and involve the patient in conversation and solving their issues. There must be a shared decision making, like a collaborative plan, action plan, identifying the right regimen and the patient choice taken with respect, and set expectations how patient can get to glycemic goals and can help them to achieve it. Now, how do you improve the patient's strategy? What are the strategies to improve patient's acceptance to insulin? Number one is facilitate interactions with the other people. We have used this method. We have a peer group who have taken insulin, and they tell to the patients, people who have little reluctance, how they feel much better, how insulin has been life-saving, how insulin has been complication-sparing, how insulin has given them better life. And also a good relationship with the healthcare team, that matters. All of us have this team which make this possible for us. And of course, today we have a lot of gadgets for education, like we have delivery of the effective and individualized diabetic education by if you have educators, sisters, face-to-face, telephone-based, or mobile apps. But one of the most important psychological interventions for overcoming this is a mnemonic called listen. And this one size fits all. List patient's concerns and fears, and give them the information which is absolutely correct and equipoise, not more, not less. Share the sources of support, where you can get support when we start on insulin, and I'm the number one to support you. Therapeutic patient education, therapeutic dieting, therapeutic patient education for insulin, and the teamwork. We need a team. We need some tools. We need some training, and then we can take care of the insulin injections for the people. Empathetic understanding, very important, and empathetic expression. This empathy, oh, it's so, I'll take care. This helps. A neutral, non-judgmental contribution. Dear friends, as I told you, we had a workshop which we have published, and we have got 3 recommendation panels. I'll go through quickly through you. Number 2, we have said that how the Indian panel recommendations on insulin distress. This was insulin summit workshop publication. Insulin distress is a part and contributes to diabetes distress. It is brought about mainly because of misconception of diabetes, because of many various factors I spoke before about insulin therapy and the lack of accurate information. One has to give accurate information. Number 3, people perceive insulin initiation as the end of the road, as all of you know, and this perception can lead to distress, which can be acute or chronic. We have to dispel it. Number 4, physicians need to apply a biopsychosocial model of health rather than a purely glucose-centric approach. It is not for a glucose control I'm giving insulin. I'm giving insulin for multifarious reasons. It's a drug, an instrument, an agent which can take care of a gamut of things. Number 2, physicians need to initiate sequential counseling and use easy to understand examples to take care of the patient. Now, what is the Indian panel's recommendation during the pre-initiation phase? Number 1, patient concerns are mainly centered around on the impact of insulin on quality of life. This we have found out by a lot of research. The pre-initiation phase, they want to know whether it will affect my quality of life. So it must be initiated, may not be the first visit, at the second or third visit, if the H1C values are high. Candidates for this counseling include those with long duration diabetes with poor glycemic control, despite on multiple OADs, and challenges faced at this stage are unique, but requires priming and reinforcement approaches. Again, a biopsychosocial model, both primordial and primary awareness is needed, and you have to create that. And the key message that has to be percolated down to the patient, that insulin therapy works, it is viable, it is safe, and it is excellent. And it just give an example. It is even used by the pregnant ladies and the children. So it has to be great. Now, what are the panel recommendations for initiation at the conversion? Patient concerns at this stage still focus on the impact on the quality of life. So safety, tolerability of the insulin reinforced at this stage. Few concerns need to be addressed, like proper injection techniques, site rotation, self-monitoring, and insulin uses, how one can use it very judiciously during religious fast, and the various ways of insulin delivery systems. Lack of diabetes educators is a challenge, but if we do it with our sisters, we ourselves, but we have many innovative solutions for delivery of open channel communications, as well as very user-friendly, very user-friendly way of addressing it. Tools that can be used by the physicians includes, we can give them starter kits, we can give them device demonstrations, we can give them the fast injection in our chamber, in our presence, they can take themselves, and it can be done very easily. Now, technology has helped us to do this. We have got patient influence is one factor, but the technology has helped us in a great way, that we have interviewing face-to-face, underlying the feeling about insulin, either direct or through the video conferencing. We have group education, empowerment of by sharing information, and also we make them feel they are educated, supported, and empowered. We have a lot of web-based programs and mobile health apps which can be given to the patient, and here the patients play an active role in ensuring their own long-term health, and they accept it. And of course, if you have educators, we do them. Does diabetes education programs improve? What are the evidences? I'll give 2 papers. One is from one of my students, Dr. Mokta, J. Mokta, published in JAPI, and you show that after the education, it has gone from a whooping from 8% or 7.9% to 42.6 to 65%. So education definitely helps, and education improves the insulin acceptance, quality of life, and well-being. And this is, we did it that time, he did it, Dr. Mokta, the round-tree group education, and has been very rewarding. Now we have motivational interview. What is motivational interview? Motivational interview is a client-oriented. Here, the person with diabetes-oriented counseling method that is thought to improve psychological insulin resistance and insulin acceptance and behavior. Now, 45 insulin diabetic patients with type 2 diabetes received 6 motivational interview sessions, and the results were significant. So MI combined with face-to-face is a great way of imparting this. Before I close, I must touch upon why we choose basal insulin as the initial insulin therapy. You know, all the guidelines, IDF, RSSDI, ACE, ADA, latest one, which came last month, IDF 2017 till 2016 said that premix can be one of the ways of starting, of initiating insulin. But today, from 2016, 2017 onwards, it has said basal is the key. RSDA 2019 said that it is basal is the way. Premix can be used. ACE said only basal. ADA said only basal. So ADA 2022 latest guideline recommend basal insulin as the quote most convenient initial insulin regimens, unquote, in patients with type 2 diabetes mellitus, and I've told the benefits much before. Dear friends, before I close, I must tell you that physicians can face resistance to insulin from their patients due to some patients' beliefs, myths, and some misconceptions, and as well as a few clinical realities of diabetes treatment. That does exist, but we have discussed today what are the solutions to overcome it. Pre-insulin education. I mean, in the beginning of diabetes diagnosis, show them that you may need it. Patients know that it's a wonderful instrument to treat. Pre-insulin education, as well as patient education at every stage of diabetes is crucial for improved insulin acceptance and adherence to insulin treatment. And we have to use simple, easy to use basal insulin accompanied by adequate insulin education to improve the adherence to insulin therapy and increase patient acceptability. Dear friends, these few tricks can provide acceptance for the insulin initiation, the solutions to the hindrances of initiation, and these small things can produce great changes and change the destiny of the patient. Thank you very much for a very patient hearing.